Okay, so welcome everybody to today's Power Hour, or Q&A session as we call them, with Dr. Anita Chandra. And I'm really pleased to introduce Anita because I think I've known Anita for 8 years. I was actually thinking back to when we first met, and it was November 2016. We met in Birmingham, if you remember, for a professionals day. And we were on the train back from Birmingham to Cambridge together, if you remember, Anita, and our train got stuck in Warwick, was it? And we bonded over cold, sandwiches and ginsters. I remember going into a cafe together, and that's when Anita and I think we talked a lot about all sorts of things. So just to give a more formal introduction, Anita, she's a consultant clinical immunologist at Cambridge University Hospitals, and she has a specific interest in primary and secondary immunodeficiency. And Anita did a lot of research focusing on primary and secondary immunodeficiency, with a special focus on a condition called as APDS, which is quite closely related to PTEN or PHTS. And Anita has, she sees patients with PHTS. And actually, I have worked on PTEN for so many years, but I would have never associated PTEN and primary immunodeficiency. And the first paper that I read, which pointed me in that direction, was actually a publication from you from 2015, Anita. And I remember reading that, and we, started talking, and you said, yeah, actually, Cowden patients do have these immunodeficiencies. And I think we spoke a lot. We put, with my supervisor, we put together, a grant to study the immune phenotypes in our mouse model for PTEN. And so I think discussions with you, insightful discussions, and your research into PTEN, PHTS, and in APDS sort of paved the way for a big research project in our lab. So lots of people from my lab have joined today because we have a genuine interest as well. So as I said, this is it's a pleasure to introduce Anita, and I'll let Anita talk all things PTEN and immunodeficiencies. So, thanks for, taking the time out, Anita. I'll let you.
Oh, thanks for inviting me, Priyanka. It's a pleasure to be here tonight. I guess you obviously probably all know a lot more about PTEN than me. And you'll know it probably from genetics, from your clinics with the cancer specialists, with the endocrinologists. But I'd like to focus on the immune system. One, because I'm an immunologist, and also because I think this is an area where a lot of patients, and actually, to be honest, even the doctors don't understand much about the immunodeficiency. You'll be really surprised that actually a lot of our geneticists and endocrinology specialists, even here at Cambridge, they don't know anything about the immunodeficiency association with PTEN deficiency. So I prepared a few slides, but they're only just a few, just as like a little bit of a prop for me, and to sort of point out a few things about the immune system. And then we'll just do free for all, and you can just ask me whatever you like, and I'll try and answer your questions as best as I can. So this is me. Next slide. Yeah, that's just my disclosures. And the next slide. Okay, so I don't want to scare you. This is, imagine you're an immune cell. You've heard of white cells. So the PTEN is part of a really important pathway called the PI3 kinase delta pathway. And this is the pathway that Bart, you introduced Bart before, has worked his entire life on this pathway. And as an immunologist, it's a really, really critical pathway because these proteins are involved in promoting development of your white cells, your immune cells. They provoke growth, differentiations, and make them specialized. So if these white cells don't work properly, you can have a reduction in the numbers, you can have few white cells, you may not be able to fight infections, you may not be able to respond to vaccines, and you may get problems with your immune system in terms of immune dysregulation, such as autoimmunity. So from an immunology perspective, I'm quite surprised that actually a lot of people don't realize that PTEN is actually very important in terms of immunity and in this pathway. And where it comes in, the reason it was sort of picked up more from the immunodeficiency point is that if we focus in on this little picture, you can see there's a little the orange and the yellow. These are two proteins that come together, and that's what's called PI3 kinase delta. And this is the enzymes. This is the protein that's affected in an immunodeficiency called APDS, of which there are lots of patients that exist, and of which I spent many, many years researching both in mouse and humans. Now, where PTEN comes in is it regulates this PI3 kinase delta protein, and it basically does the reverse. And what happens in patients with PTEN deficiency, when you lose that sort of control and that regulation of PI3 kinase delta, you get problems with that signaling pathway, and it's switched on all the time. So from an immunology perspective, patients with PTEN deficiency have a hyperactive PI3 kinase pathway, so it's switched on all the time. And immunodeficiency and immune dysregulation is a consequence of high PI3 kinase activity. Okay, so that's the science. That's as much of the science as I'm going to sort of talk to you about, just to tell you that PTEN deficiency results in hyperactive PI3 kinase delta. And that there is another immunodeficiency called APDS, in which the patients have similar characteristics. Next slide, please. So as I alluded to, this pathway is really, really important physiologically because it controls how the immune system develops. And the immune system is important for defense. So it helps you fight infections, bacterial, viral, a whole sort of infections. It helps you to regulate your body so you don't fight against, your immune system doesn't fight against yourself. That's called immune dysregulation or autoimmunity, and you don't get lots of autoimmune diseases. And the immune system is really important for cancer surveillance. People weren't really fully aware of that but in the last few decades, realized the immune system is very, very important in helping counteract and undertake surveillance against cancer. So I said in normal health, you get this fluctuating activity in that PI3 kinase. So you can see the little graph at the top, the PI3 kinase activity goes up and down. And next slide. Oh, I didn't put it in. Well, the next slide. Well, in PTEN deficiency, where we had that little graph where the activity goes up and down, in PTEN deficiency in APDS, the activity is always high. It's always up. So that whole balance is completely skewed, and you have problems with your immune system. Next slide, please. So as I alluded to before, you've got other immunodeficiency states. We've got APDS1, APDS2. These are due to patients having genetic mutations in the orange and the pink proteins. And in patients with PTEN, you have a similar feature. Because the mutation is not in PI3 kinase delta, they didn't call it APDS, but the clinical scenario is quite similar. So from an immunologist perspective, we've called it APDS-like disease. Next slide, please. So, not many people have heard of, Priyanka, she's worked on this for a long time. It was only a few years ago that you realized that there was an immunodeficiency phenotype associated. So Holm Ulnick's group has written a really beautiful review where they looked at all the different papers that featured patients with immunodeficiency. And it's not as common, as one would expect. Obviously, there are all the papers and publications about people with cancers and the neurodevelopment issues and the autism and things. But there are, and coming out probably because APDS was diagnosed back in 2013, and then people started to look in more detail at this pathway. But there have been more and more patients described who have a specific immunodeficiency. And these are just some of the papers. If there are people out there who actually like to look at papers and look at the reviews, and they're able to look at these publications where patients have immunodeficiency and PTEN mutations. So next slide. So what they've really shown quite clearly in this paper is, like, on the right, we have those patients with APDS where, remember I said the PI3 kinase activity is high, it's up, it's on all the time. That's what constitutively active means. And in those patients, they get a lot of problems with immunodeficiency. Their glands swell up, their spleen can be big. They get autoimmune problems such as like autoimmune hemolytic anemia, thrombocyte, low platelets. They can have problems with like lupus-like disease. Whereas on the left, you can see patients with PTEN deficiency, where yes, the PI3 kinase signaling is high, but it doesn't appear to be as high as the patients with APDS. So actually fewer patients are presenting with the immune side. So fewer patients have immunodeficiency, fewer patients have the big spleen or the big lymph nodes, and fewer patients have the autoimmunity side. And so what we're seeing from the publications is that approximately 10% of patients with PTEN deficiency have some issue related to their immune system. So in terms of patients, obviously, one, it's not as common immunodeficiency and problems with infections is not as common a manifestation in terms of your overall problems and clinical symptoms with PTEN deficiency. And also, there may not be an awareness with your pediatricians, your GPs, your geneticists, that actually the immune system and immunodeficiency is something that they should be aware of, and it's something that may need to be addressed in some of the patients. Because the reason why it should be addressed is, well, I can tell you a case history of one of my patients. I have an adult who has had PTEN diagnosed when he was a child. He's got asthma. He obviously has all the cancer screenings and things. And he came to me because he had recurrent chest infections. He came to me with a diagnosis of PTEN. I automatically knew straight away that obviously I needed to look at his immune system. And I diagnosed that he had low antibody levels. He couldn't respond to vaccines. He had structural lung problems because of all the infections he had. And I was able to treat him by giving him immunoglobulin replacement therapy. I gave him immunoglobulins from a healthy person. So it was like a blood donation, but it's just the immunoglobulin part. And I've given that back to him regularly. So that helps him fight infections. And so he presented as a patient with primary immunodeficiency. There are new drugs now that have been in clinical trials to treat APDS, where, remember I told you that PI3 kinase activity is switched on all the time. There is a drug that's been trialed where they switch off that enzyme. And so the levels of PI3 kinase come down and they normalize. Now that drug has been trialed now in patients with APDS, but there are going to be larger trials where they're going to potentially give it to patients with PTEN who have the immunodeficiency element. Okay, next slide. And this is just again from Holmes' paper that just shows you the percentage of patients who have the immune dysregulation side. So they have problems with colitis, maybe celiac disease, pernicious anemia, other things, or lesser so, but they can have the swollen glands, the lymphoid hyperplasia in these patients with PTEN deficiency. Next slide. Okay, so that was just the slides bit. That was just to give you a very brief overview before you want to actually fire questions at me. So my last slide was, if you do have an issue and you are concerned about any problems with recurrent infections, how do you find a clinical immunologist? Well, I've given you that, that link from the immunology.org. Basically, you get a map of England and Scotland and Northern Ireland, and you just hover over the country, and it will magically give you up a list of all the different centres with clinical immunologists. And clinical immunology services, they tend to be only in the big teaching hospitals and the big centres. But should you have any issues or any concerns about yourself or your child, whether you think they need to have their immune system looked at in more detail, you can go to your GP and specifically ask, can I be seen by a clinical immunologist? And I think that's it from my slide perspective.
Okay, that's great. I'm going to stop sharing the slides for now so we can all see each other. And yeah, if it's the way we do the Q&A is, if somebody wants to ask a question, raise your hand. If you do not want to, if you want me to ask that question on your behalf, please just put it in the chat. So while we wait for hands to go up and questions to come through, I'll start off. So it's quite interesting. You said that your patient had immunoglobulin replacement therapy. Was your patient still young when you started the immunoglobulin replacement therapy?
So I'm an adult immunologist,
Okay.
so I only see patients above the age of 16. I used to do pediatrics, but that was a while ago. So this patient actually had been symptomatic his whole life. So
Okay.
he'd had infections throughout his childhood. He'd had recurrent tonsillitis, had his tonsils taken out, had his adenoids taken out. Everyone just blamed it on his asthma. So
Yeah.
although we had the PTEN diagnosis, they were all focusing on the other aspects of PTEN and really hadn't tied the two together. And he was referred to me because of his recurrent infections. It wasn't because he had a diagnosis and they thought, oh, he must have an immunodeficiency related to his PTEN. They hadn't quite figured out that actually that was the cause.
It's linked, yeah. And I think that's a gap in the field, isn't it? Because as I said, I did my PhD studying PTEN and PHTS, and that was, I started in 2008, and the PTEN gene was discovered in 1997. So, here we are after all these years. And even now, sometimes when, you speak to somebody who has done PTEN research and you say, actually, there's, immunodeficiencies are associated, it's not something that they relate to, they correlate straight away. And there's more and more evidence coming, and it was quite interesting to see from your list of publications, most of the publications are post 2015.
Yeah,
So as
I
you
think
said,
it's
after APDS was discovered and people then started looking into it. Coming back to the question about the immunoglobulin replacement therapy, so is that something that sort of immunoglobulin levels, do they normalize back over life, or is that a treatment that your patient's going to need throughout his life? Just
unless so for this particular condition, his immunodeficiency is lifelong, so he'll need immunoglobulin replacement lifelong.
Okay, thank you.
And this is why the hope that this PI3 kinase delta inhibitor might be useful in those group of patients. So at Addenbrooke's, we have 3 patients. One's a child and there are 2 adults who have immunodeficiency with PTEN and are an immunoglobulin replacement. And I'm hoping that if they have the PI3 kinase inhibitor, they may not need that will normalize their immune system, and they may not even need immunoglobulin replacement.
Okay, that's interesting. Wendy, would you like to ask your question?
Yes, please.
Yeah.
Apologies, I may have got this a little bit wrong. It may be a little bit basic, but as you were talking, it very much felt like it felt like myself. So I'm somebody who for years, when you're talking about recurrent infections and things like that, I'm somebody who's had things like very low lymphocytes and is it basophils and think like everything that's infection wise for a long time. And the doctors always say it's nothing to worry about, don't worry about it. But I'm someone who consistently picks up colds, infections, and a normal cold wipes me out for ages. So listening to you, I was kind of like, oh my goodness, is this an answer to something that has plagued me for years? So I said to I'm actually a patient at Addenbrooke's, and I said to I am, yeah. I said to one of the geneticists a couple of years back, I think it was Jenny, is having something like low lymphocytes, etc., anything to do with PTEN? At the time she said, no, it's not. So this literally, I'm just sitting there going, oh my goodness. Because honestly, these things wipe me out completely. I don't think it's a question. I think I'm a little bit emotional. So yeah, am I a little bit basic with this, or is it along the right lines of what you're talking about?
Absolutely. You are my typical classic patient and you get referred. I will accept you straight away. Get referred tomorrow. I'm on call tomorrow and I will accept a referral from your GP.
Right.
I see
Okay.
all the
I don't have
patients
to go.
with PTEN
So
deficiency.
sorry, I didn't mean to interrupt. I literally had my review with Professor Tiskowitz.
Tiskovich. Mark. Yeah.
Thank you. Can't get it right ever. So literally just go through my GP.
Literally go to your GP. If you're Cambridge, get referred to me and you'll be seen very shortly.
Yeah,
Okay,
I'll
thank you
put
very much.
Anita's details into the chat, and
I can't
if
receive referrals directly from
directly,
patients,
yeah. No,
so
but
we'll
I
have to
think
go by
just
your GP. But I can guarantee you that if you get a referral from GP and it comes to me, it will, automatic. Well, it will go to any of the immunologists because I have a special interest. The referral will come to me for the Addenbrooke's. For anybody in the whole of East Anglia, the patients will come to me.
I'm Adam Brooks for 90% of everything for my PTEN. Oh, okay. Thank you.
The low lymphocyte count is, that's one of the things Home found, that lymphopenia is one
that's
of
your white
the
cell.
one of the main findings that he had was the lymphopenia. Okay, so we've got a question from Susie, and she asked, do autoimmune conditions present in a PTEN patient similarly to that in a non-PTEN patient?
Yes. Yes.
Okay. A question from Ryan and Bernice. What is it called that we would need to ask the doctor in order for our son to be tested for immunodeficiency? So what do they need to tell their doctor so they can get their son tested for immunodeficiency? So I'm guessing,
you say you have a diagnosis. So I'm presuming everybody on this call is a patient has PTEN deficiency, unless they're an interested
parent.
So you already have a genetic diagnosis. You would say to your GP, I have recurrent chest infections, sinus infections, or I have lots of autoimmune problems, or my glands keep coming up all the time, or I get infections that don't go away. I'm on antibiotics a lot, especially in the winter. And you just see the GP and say, I already have a diagnosis. It's related to the immune system. Please, can I get checked out by my local clinical immunologist?
Thank you.
It's as simple as that. And the GP cannot refuse. And any immunologist in this country, if you have a diagnosis, they will see you 100%.
Thank you so much.
That's great. I think there's a comment here. I'm pretty sure it's from Bart, even though it says it's from, I think it's his UCL ID or something. But yeah, it's farming plans to test the PI3 kinase delta drug. He's put a link over there about, a link from farming. And he then says Anita is likely behind this decision of farming. So yeah.
Well, yes, we're trying to actually, it's just got MHR approval, the drug. It's called Joenja, is its other name. So we got MHRA approval only 2 weeks ago, and it's going through NICE now because we're trying to get it paid for by NHS England for those patients that really need it.
And is it for?
At the moment, it's for APDS. At the moment, it's just for APDS, which is why I think it's really important to do clinical trials using it in patients with PTEN deficiency.
Okay.
Who have the relevant immunodeficiency.
Okay. Yeah, I mean, I've spoken to, the people from farming, and I know they have an interest, but it becomes very difficult because when you talk about PTEN, you do not talk about the immunodeficiencies. You talk about the cancer, you talk about the autism spectrum, the ASD, but you do, I think the awareness into the immune conditions and into the vascular anomalies, that is on the rise. More and more researchers and clinicians are talking about it. So yeah, and I have a vested interest in this because of all the research we've done, and I find it quite frustrating when I talk to somebody like farming and say it's real, and they're like, yeah, but we need more patient evidence that it is actually something quite common. And as you said, it's not something that gets, when you talk about cancer and the autism, things like recurrent chest infections, they get ignored. GP or doctor is just going to say, no, it's nothing. But it is, the immunodeficiency is real. And Catherine, yeah, I agree. Catherine said, can we do a page about this for the PTEN UKI website? I totally agree. We can put info about the clinicians, info for clinicians, example, the geneticists, about what they could request when a PTEN diagnosis is made. I think that is absolutely, it's a very good idea. We can put something together, and Anita, if I can ask you for some resources for this, it would be really good. I remember you telling me about the Jeffrey Model Foundation.
Yep.
And I remember I went on there, and it's actually very user friendly. It explains primary immunodeficiency in a very easy way. Like, even I'm not a clinician, but I was able to understand it. And then it tells you how many of these symptoms do you have. If you have more than a certain number, then you have primary immunodeficiency. Another good resource to find, immunologist in your area whom you can speak to and get, consultation. So yeah. Again, a comment from Bart. I'm also sure that Priyanka and her team's research on PHTS mice helped farming to make this decision. Research pays off. Thanks, Bart. Really appreciate that. But yeah, we are trying to do more and more research. And Anita, you're familiar with all the research. You were Georgia's external examiner, so you've read her 200-page dissertation just on the immune system.
I mean, I think it's really interesting that activity, why at APDS patients, we see many more of those. They have a more severe phenotype. And yet PTEN, like, that picture, they just a little bit, only a small proportion get immunodeficiency. But why?
It's true, yeah.
Which ones?
We don't understand.
We don't know that. Which patients? Is it particular mutation, like where it's located on the gene?
We're still trying to understand if there's a genotype phenotype correlation, and why is it that it's not very penetrant in PHTS patients. It's only a small percentage. We've got a few more questions come through. There's one from Ryan and Bernice, which is there anything we can do to help build a child's immune system to prevent him getting poorly all the time?
Well, so just general things like live a healthy life, have plenty of vitamin D, exercise, just general health, really. There's nothing specific you can do to boost your immune system. If you have PTEN deficiency and it leads to immunodeficiency, there's not a lot you can do yourself to remedy that. Just generally have a healthy life, and vitamin D is good. Vitamin D, sunlight.
Yeah. Catherine, would you like to ask your question?
Yeah, so I'm the medical trustee, I'm a geneticist.
Okay.
So we've just published a paper, and it's really observational. So we looked at our cohort of patients with PTEN, and not all of them, but most of them have had tonsils and adenoids removed in childhood. And when you look at them, they are absolutely huge. I've had one of our ENT surgeons actually diagnosed a patient with PTEN because he recognised how enormous these tonsils were. He noticed a little bit of developmental delay and a really big head in a patient, and sent them to me. Do you think that links in with the immune system, and should we be doing immune testing on all the patients, or really just those who are telling us about lots of infections?
Well, I mean, big tonsils, that's the lymphoid hyperplasia.
Yeah.
So that is the immune system. So that is an indication that the immune system is affected. I mean, I'm a bit biased being an immunologist, but I would say any patient with lymphoid hyperplasia, autoimmunity, or infections, you have a diagnosis already. Look at their immune system.
Okay. And the other thing we've noticed is that when they have their tonsils and adenoids out, they actually become a lot healthier after that, and they're not usually regrowing again. There's one adult patient who's quite unusual, whose tonsils suddenly grew in his 20s, and he rang me up sort of in a panic saying, I can't swallow properly, my tonsils look enormous. And that I thought was quite unusual. He's had them out, he's feeling better. But talking to you is making me think actually we need to go a bit further with these patients.
The tests are very simple. I think someone said, how do you test it? It's blood tests. Blood tests. So we would look at your white cells, your lymphocytes, the different types of lymphocytes. If I go into detail, they're like T cells, your B cells. We'd look at the proportion of those. We'd look at your antibody levels, your total antibody levels. Double check you've got measles antibodies. That's pretty important. People have got the measles immunity. We might do test vaccinations to see if your immune system can respond to vaccines, because that's the evidence of a normal, healthy, functioning immune system, is that if you give them a vaccine, they make a proper antibody response. So those are the sort of initial screening tests that any immunologist would do in their clinic. And then thereafter, they might, you know, if you had a history of recurrent chest infections, they might do a CT scan of your lungs just to check you haven't got, you know, lung damage. We might look at your sinuses. You might have an ENT referral if you have a recurrent sinusitis. The autoimmune things, obviously, if you have hypothyroidism, clearly they'd be treating you with thyroxine, for example. But they would do a very holistic review of everything. So unlike, say, some doctors, like chest doctors who focus on like just the chest, immunologists, the immune system is everywhere. It affects every organ. So we would look at everything.
And have you done all those tests on just a cohort of P10 patients who aren't telling you that they're having lots of
no, because I don't see them.
No.
But the one
but
from
remember, I
Holmes
said about only
paper.
10% actually have that phenotype. You know, the vast majority of P10 patients are probably absolutely fine in terms of their
I'm just thinking how much we actually ask them about it, you know, and
well,
you know, is that are we checking well enough? And I suppose they could they present later in life, so we might see them. You know, I see lots of 3 and 4 year olds, all of whom constantly have runny noses, and
and that's normal.
Exactly.
That is actually normal to have runny noses as a child and have your tonsillitis, and you know that actually is a normal. It's when you have too many, more than your peers.
And when they're, so I'm just thinking how I would think about that for this group of patients. So if they were in a younger child, if they were having lots of those infections, but perhaps being admitted to hospital, needing lots of antibiotics, maybe seeming to take a lot longer to recover than their other children, those are the things that might prompt us to say this P10 patient needs more investigations. Because I think if I sent our cohort of 50 odd patients to our immunologists all in one go, they might not be quite so happy with me. So
if you read
and helping people listening know, you know, what is the balance between what's a normal amount of infections and a response to it, and actually what is unusual as well.
If you read the paper from Nicolene's lab recently, they do say that, I mean, I don't think that was targeted to patients who had, you know, who said that they had repeated infections, and there is a high amount. And even the paper from Holmes' lab, the 2017 Hannah Chen paper, they just had 79 PHTS patients, and majority of those patients had lymphopenia. And then they say, okay, 43% patients had autoimmune diseases and stuff. So I think there are 1 or 2, you know, sort of decent cohort size studies, and it does look like it is something that is, you know, quite common. So yeah, I mean, there's the 10% estimate, but I think we do not know that. I think it's very underdiagnosed. And just being on the P10 UKI Facebook page, I have seen loads of people talk about recurrent infections and, you know, all different things, which have made me think that actually it's more common than we think. I will get back to the questions because, you know, Catherine, Anita, and I, if we start talking, that's it. We're going to keep talking forever. So I hope, Mark, that answers your question about how will an immunologist complete the immunity tests. There's a question from Pete. Are there any specific autoimmune conditions that people with P10 suffer from?
So that's a difficult question because it's whether who's looked, and I think it's only Holmes group that's actually looked and actually diagnosed. But if we compare with, say, APDS patients, if they're sort of a lot they're APDS like, then things like hemolytic anemia, so low hemoglobin, low platelets, and things like lupus-like disorders, autoimmune thyroid issues, celiac disease.
I was going to ask about celiac, because we've had a few young patients on these power hours, you know, talk about celiac. And I think one of the questions that has come up in the past, is celiac related to P10. And I probably missed that completely in Holmes' paper. I was reading that paper yesterday for my lab meeting presentation, but I missed that. But yeah, I did not know that celiac disease is, you know, something, it's an autoimmune condition and it can be related to PTEN. So yeah, we've had a few patients on here talk about celiac disease. So that's actually quite interesting. There's a question about vaccinations here. Is there anything we should watch out for with vaccinations and PTEN?
So not in terms of side effects or risks of getting having problems in vaccines, no. I think the only issue is in those very small numbers of patients who are really immunodeficient, they may not respond to vaccines as well as they should.
Okay.
So in those patients with recurrent infections, our immune workup, we would check their vaccine responses. And I would always check that people have good immunity to measles.
So what is the solution? So for example, a PTEN patient goes for a vaccination. I don't think your doctor's automatically going to check for a vaccine response. What is there a way? Can you tell your doctor that, look, I have PTEN. Could you check for a vaccine response? I don't know. I'm just trying to understand that, is it going to be too late? You take a vaccination for something, you do not mount a response, and then you take COVID, for example, right? If you do not mount a response, does that mean you need to go for more boosters, or can you ask for an antibody test to see if you've mounted a response? How would somebody who gets a vaccination, or a parent who has their child vaccinated and the child has a PTEN diagnosis, is there a conversation they can have with their doctor to ensure that the vaccine response is there, or if needed, if there isn't a decent enough vaccine response, what's the next thing? Do you get more boosters, like booster vaccination doses, or how do they navigate that?
Okay, so I would say, given that the immunodeficiency complication is rare, it's in a small proportion, and even within patients with immunodeficiencies, they can still respond to vaccines. We're talking about a very, very, very small number of patients not responding to vaccines. So my advice would be, have your vaccines. Don't worry about them, have them, because they're very helpful in preventing infectious diseases. And it'd be those patients who have the recurrent infections where it's worth just testing. Now, when we test for vaccine responses, remember I said we use it as part of our tool to diagnose patients, and we look for the antibody responses. So that's what's available in an NHS diagnostic lab. Now, you and I both know that antibodies aren't the only part of the immune system. You have T cells and you have, other parts of the immune system. And those responses we can't routinely test in terms of an NHS lab. Now, when COVID came out, and we looked at our immunodeficiency cohort, we looked at whether they could respond to the COVID vaccines. And a lot of them actually do respond. They respond, their T cells responded, and some responded also, their antibodies made an antibody response. But those tests were only available in a research capacity. So what I would say is, have the vaccines. The COVID vaccine obviously doesn't, it helps prevent long COVID and all these issues. But having the vaccine, given that the strain of virus keeps changing, it doesn't mean you won't get COVID anyway, if you see what I mean. So I would say, have the vaccine. If you have recurrent infections and pre-immunodeficiency, the best thing is to see an immunologist, because it's really the only immunologist who will then be able to test and sort of look at that more granular level to see whether you've responded to vaccines and whether you need extra boosts. Now, for most things, you don't need, once you've had one COVID vaccine, if you don't respond to it, we're not going to do anything, because people, even they're vaccinated, can still get COVID. The only thing that we would do something about or worry would be the measles.
There's a question from Pete. My daughter, age 20, has quite severe anemia. Should she see an immunologist? And I'm guessing, yeah, Pete's daughter has PTEN.
So anemia can be due to lots of different things. It can be due to losing blood, could be due to celiac disease, could be autoimmune. I think in the first instance that she should be seen probably by a hematologist, because there are many causes of anemia. And if they end up saying, well, this is an autoimmune problem, then to inform the hematologist if are they aware that PTEN deficiency can lead to an immunodeficiency as well, and immune dysregulation. But I would say that because there are so many causes of anemia, it would probably be actually in the first instance your GP to say who would be the most appropriate person to look at that in more detail.
Okay, there aren't any more questions here. Maybe I can, oh, there's another one. So this is from Becky and Tim. My son had tonsils and adenoids removed, frequent chest infections, under respiratory in Cardiff. I've asked his pediatric doctor if he can see an immunologist. He doesn't think it's something that needs looking into. Would this be worth pushing or should I wait?
How old is this child? Is he nearly 16?
He's 3.
Oh, he's 3. Okay. I think, yes, if he's having recurrent infections, you already have a genetic diagnosis that links to immune deficiency. I think it would be prudent. I'm trying to think. There's Dr. Jolanta Bertonier, who's a pediatrician in Bristol. I actually don't know the Cardiff pediatricians. The pediatric immunology centres are few and far between. They're really Great Ormond Street, Birmingham, Sheffield, Newcastle, Cambridge. There must be one, and there must be a pediatric immunologist in Cardiff. I'm just off the top of my head don't know, but I think definitely would be worth having a review, at least an initial consultation and just a screen. And then if they say that's fine, your immune system's fine, well, that's quite reassuring. I mean, remember, people can have common things like asthma, and they get recurrent infections with asthma. So don't forget, there are just common disorders. Say my example, my patient who presented as an adult, you know, everybody did attribute it to his asthma. But I think given you already have a diagnosis, it's, you know, it's very simple to just exclude the immunodeficiency part.
And is asthma something that's related to, is it considered an immunodeficiency?
No. Asthma, I just use that as a sort of common cause in the general public where they have lots of infections in the winter because of their asthma. Yeah.
Okay. Thank you, Becky and Tim. They say thank you. That's really very helpful. Okay, there are no further questions from the audience. I had a question about recurrent infections and antibiotics, because, you know, I have had patients tell me that their child has had many chest infections and has been put on really strong antibiotics like azithromycin. And I remember having this conversation with you that, you know, is that something that should be concerning, that and I think this patient wasn't even responding to azithromycin and was on, you know, like repeated courses of azithromycin over months. And I think that's when you suggested that they should see an immunologist and try and get a diagnosis for immunodeficiency. So is this something that patients or parents could look out for? Because you said that, you know, you should watch out for, you know, how many infections do you have? Do you have more infections than your peers? I wouldn't know how many infections are normal and how many are considered more than your peers. So if you could give us some sort of an indication and some of the common signs to watch out for. I don't know, your child's not responding to first line antibiotics, second line antibiotics. Is that when you start pushing for, you know, say an appointment with an immunologist? So as a parent of a child who has PTEN and has these recurrent chest infections, because I remember one of the parents saying in one of the meetings, saying, you know, how many chest infections can a child possibly have? So, you know, we do have these really young children with PTEN who have these recurrent chest infections, and then they get put on some really strong antibiotics. So I'm just sort of trying to think, you know, what sort of signs should a parent watch out for? What sort of numbers, when you say more than your peers, how many chest infections over in a year is normal, and how many should raise, you know, more than how many should be a red flag, and they should go, okay, this is something we should now try and get, you know, a consultation with an immunologist.
Okay, so it very much depends on age. And then, so if you talk about children where they are, if they're going to nursery, it is normal to go to nursery and come home straight away and get, you know, gastric flu, to get a cold. So in terms of more than your peers, you would expect a normal child going to school to catch a cold, probably 2 to 3 times over a winter period, but to get over it pretty quickly, not be bedbound, not really require antibiotics, as most kids are getting viral colds. So if they have more than 2 or 3 per winter, so, you know, we're talking about 5 or 6 over a year, having to see a GP, having to get antibiotics, coughing up sputum, coughing up green sputum, that's not normal. That definitely, I would say, you'd probably want to go in and see your GP at least. In terms of prophylaxis, when you talk about azithromycin antibiotics, so that's a standard first line of treatment for a person with immunodeficiency, is you'd give them prolonged course of antibiotics, often to cover them over the winter at least, because that's the danger time when they get lots of viral infections, and then they're a bit more immunosuppressed with the virus, and then on top of that, they get a bacterial infection. So that is the standard. First thing is that they'd give them prophylactic antibiotics. Now, if they're still getting infections despite that, then that's worrying. Why are they still getting infections? And what I would also say to the parents is, and this is with my pathology hat on, is when you often said, oh, a patient's got a chest infection or infection, what do they really mean? Because, you know, it's normal to have a cough if you've got a virus, you know, but it's not normal to cough up green sputum. It's normal to have a little bit of earache, but if you've got greeny gunk or discharge coming from your ear, that's not normal. So with my pathology hat on, I would be trying to encourage parents to say to their GP, can you, you know, don't just assume it's a viral infection, or don't just give out antibiotics like Smarties. Can you test it? Can you swab that ear? Can you take some of that sputum or horror, that green, disgusting snot? I mean, actually, snot is the easiest thing to collect. You know, I tell my patients, blow your nose into this pot, and we can send it to the lab and they can check what kind of infection it is. And then it's the pattern of infections. So if they have a particular organism, like say something called strep pneumoniae, that's a very common bacterial infection. If patients have repeatedly, you know, an organism like that, a bacteria like that, that would be sending red flags to the GP. But yeah, as a pathologist, if you've got sputum, if you've got discharge, get it tested.
Okay. Yeah, no, I think that's
equally, if you've got
really...
prolonged diarrhea, get it tested.
Okay. Yeah, no, I think that's really useful, because, you know, I wouldn't know. I'm not a clinician, and even though I do a lot of research, I wouldn't know what is normal, what sort of, you know, what are the signs one should look for, or, you know, as a parent, what are the things that should be considered a red flag and should make me go, okay, I need to now sort of try and, you know, speak to my GP, have that conversation and say, I think I need you to do something more than just, as you said, not just give antibiotics or just say it's viral, you're going to get over it. Or as, you know, Wendy said, that just say it's nothing to be worried about, because it can be, it is probably something real. And, you know, coming to the question about, you know, there's this question around antibiotics and stuff, but I think as patients, they probably get, you know, prescribed steroids, or we keep talking about rapamycin, which is an immunosuppressant. So do patients with immunodeficiencies, do they need to be cautious about, or, you know, just be aware about any groups of drugs that if they get prescribed, they should probably tell their doctor that maybe it's not, maybe they need to consider their immunodeficiency before they give them those drugs? So,
well, I think if they've got an autoimmune disease or something that requires the use of steroids, I think it would be good practice that their doctor is aware that PTEN is associated with immunodeficiency, so they can have a baseline analysis of what their immune system is before they put them on steroids.
Yeah.
Because they will be suppressing their immune system further. So I think it's always useful to know what is your starting point. And I would hope any patient with PTEN on rapamycin, rapamycin is only given in a hospital, you would be under a specialist who knew and understood that PTEN can really lead to immune problems.
I think that's more for a transplantation dose, isn't it? But for example, patients with TS, they take a 2 milligram pill every day. So my brother-in-law, he has TS, and he's on rapamycin and he takes a 2 milligram pill every day. He doesn't have, the risk of infections or anything, but it suppresses his immune system. So during COVID, for example, he had to isolate because he was on an immunosuppressant drug. Rapamycin is something that we are championing for PHTS patients to help with the cancer and stuff. But a PHTS patient who has, immunodeficiency, I personally wouldn't think that rapamycin is a good, idea or good drug for them for their cancers, because it's going to really compromise their already compromised immune system. So it's just more of, if a patient has immunodeficiency, what classes of drugs should they be careful of? And I think immunosuppressants, would you say that's the sort of broad category of drugs?
Well, that's very, very complex, because remember when I said about how important the PI3 kinase pathway is, it's for immunodeficiency, but also immune dysregulation, and you're having to balance that. So if you have a patient, say, with really bad lupus and only mild immunodeficiency, you wouldn't let them suffer with their lupus. You'd want to treat their lupus. So you may have to give them immunosuppressants, knowing that on the other side of the seesaw, their immune system is going to be suppressed. But remember, as an immunologist, I can help on the immunosuppression part. I can give antibiotics, I can give immunoglobulins. I might be able to give the Joenja in the future. There are other things I can do. I wouldn't let them suffer with their immune dysregulation, their autoimmunity, because that's the problem that's manifesting.
And I think that's a very
balance.
And it's very important to understand that immunodeficiency and immunosuppression, like autoimmunity, they are actually on two ends of the seesaw, isn't it? It's sometimes very difficult. It's very easy to think that they're all the same, but it's not, because your immune system behaves differently. And I think in general, I think for our patients to know that there is a difference, and any sort of medication that might affect the immune system can affect this, having that sort of, just knowing that from today's, over the last hour, I think it gives them that additional information they need to then have that conversation with their doctor.
But I would say that's my job as an immunologist, to keep an eye for you. So if you're on immunosuppressants, you've got PTEN, it's my job to keep an eye on your immune system and help you.
Yeah, but you know, as an immunologist, that PTEN is associated with immunodeficiency. I was talking more about patients who've not had, that immunodeficiency diagnosis because they've not made it past their GP, who do not think that there's an issue and haven't had immunology, consultation. So I think it's more from that point of view. And coming back to what Catherine said earlier, that, do we know that patients who do not present with these recurrent chest infections and stuff, do we know what their baseline immune profile looks like, even without presenting these symptoms? Because a patient might not present with any of these obvious symptoms, but might still have an immunodeficiency that we do not know of. So I think my question was more from that point of view, that are there things that people need to be cautious for? And there's another question from Catherine, and I'll take that as the last question. Or it's more of a comment. She says, this is why we wouldn't give these drugs without a clear problem that needs treating. So I agree with you, Catherine. But
I mean, a GP will not be giving rapamycin.
No.
The only time a GP might give steroids is if you've got asthma or COPD and you're having recurrent chest infections. So the very fact that they're on immunosuppressants means they should already be in a hospital setting. And then I think it's really important for that hospital doctor who's prescribing the rapamycin immunosuppressants to be aware, and maybe this is where patients have to unfortunately educate their doctor to say, I've got PTEN deficiency, can you just check that's okay, because I know PTEN is part of the relevant immune system.
And I think that's
what so I was typing was that when it's as complex as what Priyanka's describing, we need a real multidisciplinary approach. It needs the immunology and whoever else is involved in that patient's care to be talking well together, so that we come up with the best plan for people, because that's a very complicated scenario you're describing.
It is. And I have a bit of a vested interest in the whole rapamycin thing. And we have seen in our mouse models as well that even though it prevents cancer, it affects the immune system, which makes you think that is it the best drug for PTEN patients in the long run.
And that's why nobody's rushing to prescribe it unless that,
I mean, again, it's the benefits that outweigh the side effects, but there will be side effects, and knowing that, just having that information is useful. And we've had quite a few people who champion, rapamycin, and they say, can I ask for it? I think being aware that if you have an immunodeficiency and, we've had patients who've said that, they buy rapamycin from, I don't know, India or somewhere, and they sort of take it themselves. So just having this awareness that actually it might not be all bells and whistles, and, sometimes it might have side effects, and it might affect your immune system in a way you do not want it to. So yeah, it was just more sort of directed towards that, just so that, patients are aware that, it is quite a complex landscape with the cancer and the immune system, immunodeficiency and stuff. So having that just sort of a general awareness would be really useful for the patients. So it was more from that. Okay, I cannot see any more questions. Bart's left and he says, thanks for the excellent meeting. We've had a few other people. Yeah, thanks for your support of PTEN patients around the world with this Power Hour. I'm looking forward to the next one. Loads of
Somebody asked about Idaho. I don't know all the American people, but there's the Jeffrey Modell Foundation. You go up there and you can find an immunologist from the Jeffrey Modell Foundation.
Yeah. I will put up all of that information, especially there's a very nice cartoon of the immunodeficiencies one can, look into, and it tells you what are the different signs of primary immunodeficiency. So we're planning to put all of that on the PTEN
I think
UKI
Wendy's
website.
comment's useful, because you're right, a GP will Google it, will go to PTEN, and if you have these are the bloods you can do, a GP can do a lot of the blood tests.
Yeah.
And they could do them, and then they would refer the patient in and say, patient's got low immunoglobulins, got a diagnosis of PTEN, please could you kindly see?
Yeah, I think this is a conversation really maybe Catherine, you and I can have one time and try and put together a page for the PTEN UKI website, as you said, Catherine. I think that would be really, really useful. And Anita, if you're on board, we can try and coordinate that and get that up and running soon. Okay, so I think that brings us to the end of the Power Hour. Again, Anita, thank you very much. It was very useful, and it was lovely to see you again and talk to you again. So everybody, have a lovely evening, and thanks everybody for joining. And Anita, thank you again for a very interesting conversation.
Okay, thank you.
Bye bye.
Bye bye.
Thank you.